nervous system was the spinal cord and the brain. The spinal cord integrates and processes information. Remember, I told you that the information does not have to travel all the way to the brain, especially a dangerous impulse, like extreme heat or extreme, it's something extremely sharp. Okay, you can move your hand and move things away without the information having to go to the brain first. So the spinal cord has the ability to integrate and process information on its own. It can process without the brain. So it can function with the brain. It can send information up there, or it can function independently of the brain. The brain integrates and processes information. So we take information, goes up to the spinal cord, it feeds in from the body into the brain processes it and decides what we're going to do with it. Okay? So it can function with the spinal cord, or it can function independently of the spinal cord. Okay? It doesn't have to have the spinal cord to make decisions on what's going on inside the brain. Okay? So the brain can function independently, the spinal cord can function independently, or they can function together. Okay? The spinal cord is roughly 45 centimeters long. Okay? It passes through the foramen magnum. What does foramen magnum mean?
Big hole.
Big, very good. Big hole. Okay, that's the base of the skull. The foramen magnum is in what bone of the skull? Who wants to take a guess? Was that?
Occipital.
Perfect. The occipital bone. The occipital bone houses the foramen magnum. That's where spinal cord passes through. The foramen magnum of the occipital bone. It extends down the spinal column to L1. That's where the spinal cord ends. It ends at L1. Okay? But it has branches. It has a cervical region, a thoracic region, a lumbar region, a sacral region, and a coccygeal region. Same as the vertebral column. Cervical, thoracic, lumbar, sacral, and coccygeal. So those are different regions of the spinal cord. Okay. It has different features. It has a cervical enlargement, has a lumbosacral enlargement, has a conus medullaris, a cauda equina, and a fulum terminale. The fulum terminale becomes part of the coccygeal ligament. Okay. It has a posterior and anterior median sulci. That's the groove in your back along your spinal cord. Okay. So here you can see the cervical enlargement, okay, which is an expansion of the spinal cord. You see the posterior median sulcus, which is the groove that runs down through the back. You have the conus medullaris. The conus medullaris is the ending point of the spinal cord. That's where it ends, the conus medullaris. You have the tip of the spinal cord is right at L1, the inferior tip of the spinal cord. Okay, the cauda equina, below at the end of the lumbar section, and the filum terminale, which forms a coccygeal ligament. So those are different features of your spinal cord. Okay, the spinal cord has 31 spinal segments. Okay? Each segment has a dorsal root and a dorsal root ganglia, where the nerves are. Has a ventral root and a spinal nerve where it comes off. The spinal nerve is both afferent and efferent. Okay, the dorsal root is afferent where information comes in. The ventral root is efferent, information goes out. Notice there is no ventral root ganglia. There's only dorsal root ganglia. So on the exam, if I list several features of the spinal cord and you see ventral root ganglia, you will mark that as false because that does not occur. Okay? There's no such thing as a ventral root ganglia. Okay? Again, here was your cervical spinal nerves, thoracic spinal nerves, lumbar spinal nerves, sacral spinal nerves, and coccygeal spinal nerves. And they branch off the spinal cord. Okay? And this is what we're talking about. This is a cross section through the spinal cord. Make this bigger. Can I make this bigger? I can do it this way, I guess. Okay, so this is the dorsal root. This is the posterior. This is the posterior median sulcus. Well, let me draw on this one. Go back to here. Okay. So this is your posterior median sulcus. Sulcus just means a groove here. Okay. This is the anterior median sulcus. So cross sections are always erased. So the front is towards the bottom, back is towards the top. So this is posterior. This is anterior. Okay. So this is the dorsal root here. This is the dorsal side. Okay. You have a dorsal root ganglion. That's swelling there where all the cell bodies are. That's your dorsal root ganglion. Then you have your ventral root coming out the anterior surface, and that feeds into the spinal nerve. So the spinal nerve comes in, and the afferent portion goes to the dorsal root, and then comes out the ventral root with the efferent. You'll see some better pictures in a second coming up here. So features of the spinal cord, we talked about a little bit before. The transverse view, and you cut across cross-section. You have white matter, you have gray matter. You have the central canal. Central canal is the cerebrospinal fluid. You have the anterior median fissure and the posterior median fissure. What is the difference between a fissure and a sulcus? There really isn't. A fissure is a deep sulcus. And there's no magic number. I mean, if it looks deep to you, it's a sulcus. If it's not as deep, it's a fissure. That's all. But there's nothing that says like 2 millimeters is greater than that as a sulcus or less than that as a fissure. There's nothing like that. It's just a fissure is a small sulcus. Though the base is the same. Again, so your posterior median sulcus in your white matter, your anterior median sulcus in your white matter, ventral root, dorsal ganglion, central canal, cerebrospinal fluid, and your spinal nerve. Okay. So feature of the spinal nerve, what's coming off your spinal tract. Okay. They're mixed nerves. Mixed nerve means they are afferent and efferent. They send information in, information goes out. Okay. So sensory is afferent towards the spinal cord. Okay. Motor is efferent away from the spinal cord. Just like we talked about before. Okay. You have protections. Of course, protects your brain. Okay. These are all your meninges. Right. They're special membranes that provide protection, stability, and absorb shock around the brain and the spinal cord. Okay. They're continuous with the cranium, the cerebral meninges. They continue down into the spinal cord. Denticular ligaments from these anchor the spinal cord in position. They're little ligaments that form from the meninges that help hold the spinal cord in position and don't allow it to move. Okay. So here are denticular ligaments. Okay, these right here. You see how they pull up? And these are connected to the spinal cord to keep it in place. So here's the spinal cord. We have different layers of this. We're going to go over these just a little bit here. We have the pia mater, which is the innermost layer. We have the arachnoid layer, which is the next layer. You can see that reflected here. And we have the dura layer, which is the outer layer. So the pia mater is like saran wrap. It's a very thin, clear plastic coating around the spinal cord, around the brain. Then the next layer is a little thicker. That's your arachnoid layer. Then the dura mater is the thickest of them all, which is a hard outermost layer that helps protect it. Okay, so 3 layers of the spinal meninges, 3 layers. Same with the brain. We have dura mater, which is the outermost layer, tough, fibrous outermost layer. We have the arachnoid layer, which is your middle layer, kind of a little bit less tough. And the pia mater, which is the innermost layer. That's very delicate. Like I said, it's like saran wrap on the brain. You can't hardly see it. If you peel on it, it peels right off. But it's in direct contact with the cerebral cortex. Okay, so this is what it looks like. Here's your spinal cord. Okay, here's your gray matter. Okay, there's your white matter. You can see the gray matter is the cell bodies. White matter is your axons that form tracks that come up and come out. The ventral, here's your spinal nerve that comes out through here. Coming in, goes to the ventral root. coming in, I'm sorry, this is backwards. Coming in comes through your dorsal root ganglia, and going out back through your ventral root, forming your spinal nerve. 3 layers of your pia mater, which I said is a real thin layer that's in direct contact with the spinal cord. The arachnoid matter, which is a little bit thicker, and the dura mater, which is a really tough fibrous coating that's on the outside here. So 3 layers: pia mater, arachnoid, and dura. Okay, dura mater. Dura mater is the outermost layer. Okay, it's the toughest of the 3. It helps to stabilize the spinal cord within the vertebral column. It has cranial and sacral attachments that stabilize the longitudinal axis of the spinal cord. So it anchors at the top, anchors at the bottom. They help stabilize the length of the spinal cord. The arachnoid mater is the middle layer. It's separated from the pia mater by what's called the subarachnoid space. So if you have 3 layers, you have the dura mater, you have the arachnoid mater, and you have the pia mater. That's an A. Okay. So between the pia mater and the arachnoid mater is the subarachnoid space. And the reason that's important is the subarachnoid space is where the cerebral spinal fluid flows. So this is your cerebral spinal fluid. And remember, the pia mater is in direct contact with the brain tissue. So it can easily transmit nutrients, things like that, take away waste from the pia mater, from the brain cells. Okay? So the cerebral spinal fluid flows in contact with the brain just above the pia mater, which is really thin, really easy to penetrate with the cerebral spinal fluid, with the nutrients in it or the waste it has to get into the cerebral spinal fluid. Okay? So the cerebral spinal fluid is in the subarachnoid space, the space below the arachnoid layer. Okay? So the deepest medial layer is the pia mater. Okay? That's where the blood vessels are found, which makes sense because you have to have oxygen, CO2, oxygen get in, CO2 get out into the bloodstream, and it can't go through the thicker fibrous layers. So all your blood vessels are in the deep layer of the pia mater. The pia mater is real adhesive, I want to say, to the spinal cord. It sticks really, just like wrapping saran wrap on something. It's real thin, real delicate, but it sticks to it really well. It's firmly bound. Okay. So gray matter of the spinal cord column is your central canal. Consists of your cell bodies. Okay, cell bodies surround the central canal. It consists of glial cells. Okay, that's what controls or modifies the cerebral spinal fluid. The white matter consists of axons. Okay, they're oriented into tracks or columns. Okay, they're loaded outside the gray matter area. Okay. So outside of the cell bodies, you have the axons that are myelinated, that travel in tracks or columns, okay, and that is your white matter. Organization of gray matter. The somas are organized into nuclei. You have sensory nuclei or motor nuclei. Sensory nuclei, it's where the information comes in, and the nuclei decides where to send it in the brain, what part of the brain. Parts of the brain have different functions. Or the information going out goes to motor nuclei. And the motor nuclei decides which muscles to send that export or that information to. In a transverse view, we're going to show you the posterior gray horns, the lateral gray horns, and the anterior gray horns, and the gray commissure. Commissure just means a crossing over or connection between the right and left sides. The commissure. So the organization of gray matter has posterior gray horns, somatic, sensory, and visceral nuclei. Okay? So that's your sensory input, both visceral and somatic. Okay? Lateral gray horns. Lateral gray horns are your motor nuclei, your visceral motor nuclei. Okay? What controls your glands, your smooth muscle, your cardiac muscle. The anterior gray horns are your somatic motor nuclei. So this is your visceral, this is your somatic. So for the posterior gray horns, the cell bodies, the somatic and visceral are combined. Okay? There's a sensory input. The lateral great horns and the anterior great horns are separated. The lateral great horn is your visceral motor nuclei output, and the anterior great horns is your somatic motor nuclei. And the great commissure, okay, are axons crossing from one side to the other. This is a good picture of it. This is exactly what we got. Okay, so this is your median, your posterior median sulcus. This is your anterior median fissure. That's where we're aligned. So if we're looking at this is your dorsal root. Dorsal root is coming in. Your dorsal root is afferent. Information comes in. You have a dorsal root ganglia, which is your swelling here where the cell bodies are, where neurons connect, and then the next neuron transfers that information. Okay? And this is your ventral root. Ventral root is motor. This is where your efferent information comes out. Right. This is you can see the gray area here. This is your posterior gray horn. Okay. This is the lateral gray horn. And this is the anterior gray horn. Okay, you can see the horns are just in different areas. This is the central canal. Cerebrospinal fluid runs right through there. Okay. And for your input, remember we have somatic and visceral coming into the posterior great horn. For your output, the visceral, okay, smooth muscle, cardiac, stuff like that, comes into the lateral, the lateral great horn. And for the anterior great horn is the somatic output, control of your skeletal muscles. So that's how the great horns are broken down in the spinal column. That's how information comes in, information goes out. Okay. The white matter consists of columns of nerves called funiculi. That's your white matter. That is the myelination of the sheath of the axon. You have a posterior white column, you have an anterior white column, and you have a lateral white column. Just like we had with the gray column.
Are you trying to shop for poster white collar?
That was my Alexa. I guess it heard so.
Amazon's choice is Echo Dot, 3rd gen, smart speaker, charcoal. It's $39.99. With delivery by October 2nd.
Alexa.
Tuesday.
Stop.
Wow, we can't even have class now without ads.
I know, it's crazy. It's just behind it. It helps you when you do things, but I didn't think it'd be activated. I could unplug it. So the columns of the columns are your posterior white column, your anterior white column, your lateral white column. Columns can be either sensory tracts, which are ascending, coming in, or motor tracts, which are descending, going out. So those are your columns. And it's the same thing as the gray matter, posterior, anterior, and lateral. Okay, so here's your columns. Okay, this is your posterior column, your lateral column, and your anterior column. Okay, that's your white matter. These are all your axons coming in and into it, okay? So posterior, lateral, and anterior. And if you look at the different areas, this is your input from your legs, your hip, your trunk, and your arm. You notice the further down your body, the closer it is to the midline. We'll get into that in a little bit. Those are what's called homolucus. Okay? Different areas that represent different parts of the body. Okay? Those are your input into the posterior column. The lateral column has input, and then the anterior column. And again, you have the extensor and flexor muscles, hand, forearm, arm, shoulder, trunk. Okay? As you get closer, it gets more towards the external here. So this is your efferent columns. These are your afferent columns on the top. Okay? There's 31 pairs of spinal nerves. It matches our vertebrae. There's only 7 cervical vertebrae, but it starts at the top of the first cervical vertebrae. So there's going to be 8 cervical nerves, even though there's only 7 cervical vertebrae. That makes sense? Because you're starting above it. Then there's 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. So there's 31 pairs of spinal nerves in the human body. Okay, here's your cervical spinal nerves. Here's your thoracic spinal nerves, your lumbar spinal nerves, your sacral spinal nerves, and your coccygeal spinal nerves. Okay. Spinal nerve. Each nerve consists of 3 different components, basically. Has an epineurium, a perineurium, and an endoneurium. The epineurium is the outer layer, and it becomes continued with the dura mater, the hard, thick, fibrous layer. That surrounds the entire nerve, surrounds the entire spinal nerve. So you have your epineurium. And in between, under that, you have your perineurium. The perineurium surrounds each fascicle, each bundle of axons. And the endoneurium surrounds a single axon. So it's different layers, an epineurium, perineurium, and endoneurium. All right, that's what it looks like. This is your epineurium. Here's your spinal nerve. Your epineurium is this layer right here. It becomes continuous with the dura mater. And that surrounds the entire neuron, the entire spinal nerve. Then you have your perineurium. Your perineurium is this right here. And this surrounds each fascicle or grouping of axons. This is your perineurium, around each one of those. Then you have your endoneurium, which surrounds each individual axon. Okay? So your epineurium, perineurium, and endoneurium. 3 different layers of spinal nerves. You have distribution of spinal nerves. Spinal nerves form 2 branches, a dorsal ramus and a ventral ramus. Spinal nerves T1 to L2 have 2 additional branches beside the other one. They also have a white ramus and a gray ramus. Okay, if you combine both these together, you know they're known as the rami communicati contact. It's only from T1 through L2. Motor impulses lead the spinal cord via the ventral root. We talked about that. The dorsal root is your input. The ventral root is your output. So sensory information enters the spinal cord through the dorsal root. That is your afferent system. Efferent goes through the motor impulses through the ventral root. So the rami communications of white and gray rami innervate your smooth muscle, your organ. The dorsal ramus innervates skeletal muscles of the neck and the back, and the ventral ramus innervates the skeletal muscles of your limbs. And this is your spinal nerve being formed here. Again, this is your dorsal root and dorsal root ganglion. This is your input. Okay? Again, you see your spinal nerve is down here. This is your spinal nerve, this thing right here. It has both things. It says input and output. Okay? So input comes into the dorsal root, comes out through the ventral root, okay? And it breaks in different pathways. It goes into the dorsal ramus, which goes to the muscles of the back, skeletal muscles of the back, ventral ramus, which goes to the skeletal muscles of the body and the limbs. And then it forms the white ramus here and the gray ramus, rami communicatis, together. And those innervate into the rest of the spinal nerve, into the sympathetic nerve. It goes to the postganglionic fibers and smooth muscles. Okay. So that's how it's distributed for your spinal nerves. Okay. And this is the first one. Let me go back a second. How do we go back this way? Okay. You can see this is all the exput. This is all coming from the ventral root. And remember, ventral roots have no ganglia. So it's just the input going directly from it. And this is the way it can branch through the different rami. Okay? Dorsal ramus, the ventral ramus, or the rami communicantes. We go to different areas. Now, input, if it comes from exoreceptors, proprioceptors at the back, mesoreceptors at the back, and it comes in and enters the dorsal root ganglia, into the dorsal root, into the gray matter. That's the input. And again, it still goes through the dorsal ramus, the ventral ramus, and the rami communicantes. So it goes through the same pathway. It's a mixed nerve, has both functions of afferent and efferent. Okay, who's paying attention? What's the red line pointing to?
The dorsal root.
Perfect. Pointing to the dorsal root. What's the one below it pointing to? This area right here.
The dorsal ganglia.
Dorsal root ganglia. Perfect. What's this one pointing to?
The central canal.
Perfect. Central canal.
Oh,
And then this one. This is your what? This is a combination of the dorsal root and the other one. Forms what?
Spinal nerve.
Spinal nerve. Okay. And this is the other root, which is what?
ventral.
It's the ventral root. Remember, the ventral root has no ganglia. Only the dorsal root has a ganglia. Okay. What's this area right here?
Commissure.
Commissure's up here.
Oh,
Next, right and left. This is the posterior median fissure. Prominent or anterior. Let's say posterior. Anterior median fissure. And this one here is the
posterior median sulcus.
sulcus, posterior median sulcus. And the difference between a fissure and a sulcus is the fissure is deeper. So what's the first one?
Epinurium.
Epinurium. Perfect. All right, cross that one off. What's the next one? The next one's pointing to
Perinurium.
the perineurium, which is layer inside of that. And the next one's pointing to each individual axon, which is
Endoneurium.
endoneurium. Okay, and this was pointing to
Myelinated axon.
that is a
Myelinated axon.
yeah, or swan cell. That one's actually pointing to the swan cells. Because this is the axon here, that's myelinated. These are the swan cells that surround it that create the myelination. I know that was kind of confusing. So that's the swan cells that create the myelin, and this is the myelinated axon. Because here's the axon, and that's the myelination around it. So, but that's confusing. You go either way with that one. And the last one is a
Fascicle.
fascicle. That one's tough.
That was so hard.
You know. Dermatomes. Okay. You do surgery. The body's arranged in dermatomes. So each paraspinal nerve has a specific surface area. So the clinical report regarding surgery. So when you do surgery, you know which nerve supplies which area, which is important if you're going to give a block, because you want to block the nerve that controls the area where you're doing the surgery. If you block the nerve of a different dermatome, it's not going to be helpful if you do the surgery. Okay, so everything has a different dermatome which you're going to pay attention to. Okay, now we got nerve plexuses. A plexus is a group. It's Latin for braid, to intertwine. It's a group of nerves that are kind of tied together. It is like a plexus, like a spider web that all comes together like a braid. Okay? It's a branching network of nerves. And it's a group of them. Okay? And there's different divisions, 4 basic divisions of the plexuses of the spinal nerves. There's a cervical plexus, there's a brachial plexus, there's a lumbar plexus, and there's a sacral plexus. And some people combine the last two together with lumbar and a sacral plexus. Okay. And here is your cervical plexus coming off the cervical nerves. Your brachial plexus, lumbar plexus, and sacral plexus. One of the exams on your nursing tests every year is where is the thoracic plexus located? There is no such thing as a thoracic plexus. Okay, so it's none of the above when you see that. There is no thoracic plexus. There's a cervical, a brachial, a lumbar, and a sacral. And they get people all the time to that question. Cervical plexus is C1 to C5. consists of cutaneous and muscular branches. The cutaneous branches branch to the head, the neck, and the chest. Up in the cervical area. Consists of cutaneous muscular branches. The muscular branches innervate your omohyoid, sternohyoid, geniohyoid, thyrohyoid, and sternothyroid. Innervates the rhomboids, the serratus anterior muscles, the sternocleidomastoid muscles, and the diaphragm. Okay? So the diaphragm is controlled from the cervical plexus. A branch of that cervical plexus forms a phrenic nerve. So the phrenic nerve is a nerve that is directly responsible for the contraction of the diaphragm that causes you to breathe. If the phrenic nerve gets severed, trauma, accident, whatever caused it to be severed, the diaphragm does not contract. You'll be on a respirator. Okay? So the phrenic nerve is the one that controls your diaphragm, and that comes from the cervical plexus. It's your phrenic nerve. So here's your cervical plexus. And again, you can see the cervical area, and it looks like a braid or spider web of all these things intertwined. That's what a plexus is. It just means a grouping that's all matched together in this spider web or trabeculation pattern. Okay? So the cervical plexus originates from the ventral rami of the second, third, and fourth, and fifth cervical nerves. The phrenic nerve, again, the phrenic nerve here innervates the diaphragm, and it is a branch coming off of the cervical plexus. So you can see the plexus up above it. You see the phrenic nerve right here as it runs down, coming up from the cervical plexus. The brachial plexus. Okay. This innervates the pectoral girdle, your shoulder, and your upper limb. Okay. Brachial artery, brachial plexus comes off the shoulder, innervates up into the pectoral girdle and your upper limbs. The ventral rami emerges from C5 to T1, and it forms the superior, middle, and inferior trunk. So 3 trunks branching form this brachial plexus. That's what it branches into. Okay? And the trunks form different divisions. The trunks form an anterior and posterior, and the divisions from the cords, those are the posterior, lateral, and medial. And the cords form from the spinal nerves as these branch. So once your plexus branches, it forms these different divisions. And this is what it looks like. Here's your spinal nerves coming out. This is your brachial plexus right here. Okay? It forms 3 trunks, right, when it breaks off. Superior, middle, and inferior. Each one of those trunks forms a lateral, posterior, and medial cord. Okay? So you have your brachial plexus. Brachial plexus forms a superior, middle, and inferior trunk. So 3 trunks. Each of those trunks then divides 3 times. 1 lateral, 1 posterior, and 1 medial cord. And each of those goes into different nerves that innervate the shoulder, upper part of the arm, lower part of the arm, and the hand. Okay. So there's your brachial plexus, C5 to T1. Okay, the brachial plexus forms of 3 trunks, superior, middle, and inferior trunk. Okay. The cords of that, the lateral cords extends from the musculocutaneous nerve. The lateral cord and medial cord extend to form the median nerve. The medial cord extends to form the ulnar nerve. The posterior cord branches to form the radial nerve. These are nerves that innervate the hand, and these are the nerves that are responsible for repetitive motion disease. I'm drawing blank what it's called. When your fingers go numb. Dang. What's the problem? You pinch your nerves. I'll think of it. Can't think of it right now. Strong blank on the word. Okay. So here's your different divisions again. You had your brachial plexus. Okay. Superior, middle, and inferior trunk breaks into the medial cord, posterior cord, lateral cord. And here's the nerves that are formed coming off of it. Axillary nerve, medial cutaneous, medial nerve, ulnar nerve, radial nerve. Okay. As it goes down the arm. Okay. So there's the plexus. Here's the radial nerve. Again, the radial nerve can travel on the thumb side. Ulnar nerves can travel on the medial side. And the median nerves can travel between the two. Okay? And it innervates down through the wrist here. Carpal tunnel syndrome. That's the word I couldn't think of. I knew it'd come to me. Because these are the 3 nerves responsible for carpal tunnel syndrome. Your hand goes down from repetitive motion or from infringement upon the nerve. The radial nerve innervates this area right here. So if the area below your thumb goes numb, it's the radial nerve being impinged upon. Okay? The median nerve innervates the thumb and the first 2 digits, and half of the third. If those are the areas that are numb, it's the ulnar nerve, it's the median nerve, that's being infringed upon when it goes through the wrist. And if it's the ulnar nerve, it's half of number 4 and number 5 digits are what goes numb or becomes painful. So depending where the numbness is, depending where the surgeon is going to cut to relieve that area. So when you have carpal tunnel surgery, you have to know which fingers are numb to know which nerve needs to be relieved. Right? And that's from the brachial plexus. And here's a brachial plexus on a cadaver. You can see all the nerves bound together. You can see the cervical plexus above that right here. Those are grouped. Okay. You can see the different trunks and the separation. Then you have the median nerve, which branches down. You have the radial nerve. It's going to go on the thumb side. And you have the ulnar nerve, which is going on the median side. Okay. And as they branch down, if you follow the median nerve, you can see that running right through here, right through the middle. Okay. And the median nerve is responsible for your thumb, and the first 2 digits, and then half of the 4th digit. So it takes care of the cerebral plexus and the brachial plexus. Okay. And now we got the lumbar and sacral plexuses. Okay, this is T12 through S4. Okay, also called the lumbosacral plexus. That's when you combine them together. The lumbar plexus goes from L1 to L4. The sacral plexus goes from L4 to S4. Okay. So here's the lumbar plexus. And again, you can see the nerve, the groupings here as they form a braided area or trabeculation pattern. Okay. Major nerves of the plexus for the lumbar plexus is a femoral cutaneous nerve, genital femoral nerve, and the femoral nerves. Okay. And the sacral plexus. Okay, L4 to S4. Okay. This one joins the sacral, this one. Okay, L4 to S4 is part of the ventral ramus of L4 and the ventral ramus of L5. And it forms a lumbosacral trunk, which joins the sacral plexus. Okay. And coming off of the sacral plexus is the sciatic nerve. That's a big important nerve. That's the nerve that controls most of your leg. Okay, the branches into 2 nerves and it's on the lower part of your leg. That's the one where you give injections into the buttocks area. That's the one you make sure you miss. That's where you go high and lateral. Make sure you don't hit that sciatic nerve. Patients will not like that. So the lumbar plexus forms a genital femoral nerve, the lateral femoral cutaneous nerve, the femoral nerve, the iliohypogastric nerve, ilioinguinal nerve, and the obturator nerve. Those are the nerves that come off of the lumbar plexus and the areas they innervate. Okay. You can see from the lumbar plexus, you can see the different nerves. The iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous nerve, femoral nerve, and the obturator nerve, where those are located. Again, coming off the lumbar plexus. Sacral plexus, we said was L4 to S4. Well, the sciatic nerve. And the sciatic nerve comes down, and when it reaches the patella area, right at the kneecap, it forms a common fibular nerve and the tibial nerve. It runs down the fibula and the tibia. Okay. Sciatica is one of the diseases of the sciatic nerve when it gets impinged upon. It causes severe pain when someone tries to walk or stand for long periods of time. It also branches into the pudendal nerve, the superior gluteal nerve, the inferior gluteal nerve, and the posterior femoral cutaneous nerve. Okay, those are all nerves that branch off from the sacral plexus. And here you can see again, this is a sciatic nerve that you can never miss. That's the biggest nerve running down. When it reaches the patellar area, it branches into the tibial nerve that runs on the tibia and the common fibular nerve, which runs around the fibula. Okay. You can also see your superior gluteal nerve, your inferior gluteal nerve, your posterior femoral cutaneous nerve, your pudendal nerve, and your and then we saw the sciatic nerve where it branches. Okay. Again, you see different muscles having cut away to show the nerve. Gluteus maximus is the outermost portion in the buttocks area. Underneath that is a gluteus minimus. Underneath that is a gluteus medius. Okay. And then you can see a superior gluteal nerve. You can see the inferior gluteal nerve just below it. You can see the pudendal nerve. Okay. Posterior femoral cutaneous nerve. And this is your sciatic nerve coming down, always the thickest one. The biggest, thickest one is sciatica. Once it reaches the patellar area, it branches into two nerves, the tibial nerve and the common fibular nerve. Okay. This is a dissection that allows you to look at it. Then you can see the pudendal nerve has been dissected out right here. You can see this is the gluteus maximus that's been cut away. This is your posterior femoral nerve. And this real thick nerve right here with like three different bundles that's heading down the leg, upper part of the leg. That is your sciatic nerve. The largest one is going to that area is going to be the sciatic nerve. Okay, you can see the piriformis muscle that they dissected out. You see the inferior gluteal nerve. You can see the gluteus medius muscle here. You see the superior gluteal artery and nerve. And you can see the gluteus maximus, which is the outer leg that's been cut away. Okay. And these are the branches of the sciatic nerve, the tibial nerve and the common fibular nerve. You can see those are fairly large nerves on their own, but those are the branches from the sciatic nerve, and it branches right at the patellar junction. So summary, cervical spinal nerves come from C1 to C8. Thoracic nerve, thoracic spinal nerves come from T1 to T12. Lumbar spinal nerves come from L1 to L5. Sacral spinal nerves come from S1 to S5. Coccygeal spinal nerves emerge from coccygeal number 1. Okay. Why does it say thoracic spine nerves? What do we say there's no thoracic what? There's no thoracic plexus. Okay, there's not a grouping. There's individual thoracic spinal nerves. They just don't form a plexus. They don't form a group and braid together and branch in other ones. They come off individually in the thoracic region and innervate their target organs or target muscles. All right. So look at the choices on the left. What's the arrow pointing to?
Cervical plexus.
Cervical plexus. Perfect. Below that,
Brachial plexus.
brachial plexus. Below that,
Lumbar plexus,
lumbar plexus. Good. Below that,
sacral plexus.
Sacral plexus.
sacral plexus. I'm not sure which one's next, but it's probably the way I do things. Probably going to go there. So go with like circular orders. All right. What's that?
Sciatic nerve.
Very good. The big, thick nerve you can't miss. Sciatic nerve. And what does sciatic nerve break into? What two nerves?
Tibial and a common fibular.
Perfect. The
What
tibial
Jonathan
nerve.
said.
Perfect. And where does it break? Where does it divide at? What location?
The pop.
The patella, right?
Yeah.
The kneecap. And what does the next one point at to?
Musculocutaneous nerve.
I wonder how you guys do that one.
What she said.
The musculocutaneous nerve. It branches down the arm. All right, perfect. The summary of the nerve plexus. Remember, with the nerve plexuses, there is no thoracic, but there are thoracic spinal nerves. They just don't form a plexus. Plexus means a braiding or trabeculation, like a spiderweb pattern in group. So the cervical plexus goes from C1 to C5. The brachial plexus goes from C5 to T1. There is not a thoracic plexus. A lumbar plexus goes from T12 to L4. The sacral plexus goes from L4 to S4. And there's no coccygeal plexus either. So cervical, brachial, lumbar, and sacral. Okay, and you can see them here. This is your cervical plexus. Again, you see how they brand together. This is your brachial plexus, how they group together. And see each of these individual here? There is no plexus for the thoracic nerves. They just branch off as individual spinal nerves. In the lumbar plexus and the sacral plexus. You see how they group together. Okay, and you can see the sciatic nerve being formed, which is, like I said, you're not going to miss sciatic nerve. That's a huge nerve that runs down the leg. All right, perfect. We're talking a little about reflexes. The definition of a reflex, you need to know this for your nursing exams. Reflex is an immediate, involuntary motor response. You have to know those three things. It has to be immediate. A reflex cannot be a day later. That's not a reflex. Reflex has to occur right away. It has to be involuntary. You can't control it. You have no control of the reflex. The reflex just happens. It's not something you think about and go, I think I'll do this in response to this. No. And it has to be a motor response. You got to move. It's got to be, something's got to be triggered. Okay. We have what's called a reflex arc. Okay. The reflex arc is a wiring of a single reflex, how it's wired. Remember, our body works on electric currents, just like a circuit board. Okay? It's the wiring of a single reflex. It begins at a sensory receptor. You have to start a reflex at a sensory receptor. There's got to be input. Something has to trigger it. So you have to have a stimulus. So all reflexes start at a sensory receptor and end at a peripheral receptor. Okay? So the pathways of reflex arc, you get activation of the sensory receptor. There has to be a stimulus that causes that nerve to fire for active potential. It relays information to the central nervous system, spinal cord of the brain. That information is processed. Now again, it doesn't have to go to the brain for processing. It can process right within the spinal cord. Okay? It can go to the brain for processing, or it can go to the spinal cord for processing. But the information has to be processed. Something has to decide what to do. Then you activate a motor neuron. Okay? And then you get a response by the effector, the outgoing control. So you've got to have a stimulus. You're going to make a response. It has to be immediate. And it has to be involuntary. Okay? There's different types of reflexes. Okay? We're going to go through the different types and do a little kind of exercise to help with that. So reflexes are classified their development. They're either innate or acquired. Innate means, I lost my picture here. There we go. Got it back. Innate. Innate means you're born with it. Okay? You don't have to learn it. It's an automatic reflex. When a baby sucks on a breast, that's an innate reflex. Okay? They didn't have to learn it. It didn't have to be taught. It's just an automatic reflex. Okay? Acquired. Acquired means you had to learn it. I used to use the example when you see a yellow light, what do? You don't have to think about it. Your foot goes to the brake. And all my students are saying, no, it goes to the gas pedal. So you get through the intersection. Well, no, it's not how it's supposed to work. So I don't use that example. When you see a red light, a required response is to put your foot on the brake. Okay, you see the red light, you don't think about it. You respond automatically. You don't have to think that, oh, it's a red light. You've learned that, though. You weren't born with that. Okay? You had to learn that. That's acquired. So there's two of them. There's innate and there's acquired. and the site where the information is processed. Remember, it can be processed in the spinal cord. It's like you put your hand on the hot stove, or you step on a Lego. Okay, you step on a Lego with your bare foot, it's an automatic response. Okay, that goes to the spinal cord. It doesn't go to the brain. It will eventually, but it goes to the spinal cord, it gets voted on. So it can be a spinal response, or it can be a cerebral response. It can go to the brain, you can think about it, and then come back. Okay, the nature can be somatic, which means the muscles are involved, muscles contract. It can be visceral. Okay, visceral means a gland, sweat glands released, hormones released from the pituitary gland, apical gland, like when Melican glands release milk from the breast when the baby sucks on it. Okay, that's a reflex. Okay, or it could be autonomic, parasympathetic, or sympathetic response. And it can be the complexity of the circuit. The circuit can be monosynaptic. It goes, hits one synapse, and goes right back out. Or you can have several synapses it bounces off to get to certain areas, and then comes back out. So monosynaptic or polysynaptic. So those are all different classifications of reflexes. And they all make sense. I mean, innate or acquired, spinal or cerebral, somatic, visceral, or autonomic, which is your peripheral nervous system, your parasympathetic or sympathetic nervous system, and monosynaptic or polysynaptic. With all the different variations you can have with reflexes. Okay, so here's a reflex, and this does not go to the brain. This goes to the spinal. This is what we're talking about. Here's your stimulus. You put your hand on attack. It hurts. Okay, you immediately have your receptor. You have your stimulus. It goes through the dorsal root ganglion. Goes through the dorsal root. Okay, comes into the spinal cord. The spinal cord has a interneuron here. Okay, it comes back out. Ventral root goes to the muscle, and you move your hand. That's your response by the effection. That is a spinal cord reflex. It does not go to the brain. Okay, you put your hand down, it moves extreme. You step on a Lego, you put your hand on attack, you move really quick because it hurts. Okay, it moves so fast it doesn't have time to go to the brain. It's a spinal cord reflex. Okay, it's called a reflex arc. Okay, so here's your sensory neuron. This right here is your sensory neuron. It brings information into the central nervous system, which is in this case is the spinal cord. Then you have your interneuron. Your interneuron is only within the central nervous system, and it relays that information to an efferent neuron, which is your motor neuron, and it comes out the ventral root. Remember, afferent information comes into the dorsal root. Efferent information goes out the ventral root. Okay, here's it all. This is a great little slide. I like these little slides that they do to summarize everything because everything's in one place. You can see it. So innate reflexes, you have two types of reflexes, innate or acquired. Innate is genetically determined. It's a good one for innate. Gag reflex. When they're in my office, we hold your tongue with a mirror and look around and people somebody gag. That's an innate reflex. You didn't have to learn how to gag. You can gag or put your tongue back far enough, you'll gag. Okay, that's genetically determined. Okay, acquired reflex is a learned reflex, like putting your foot on the brake at a red light. Okay, a response. Okay, response can be somatic or it can be visceral. Somatic is your skeletal muscles contract. Okay, this includes your super and your stretch reflex. Stretch reflex are really kind of interesting thing. We'll talk about in just a minute here too. And then your visceral reflex, okay, which acts as a smooth muscle, cardiac muscle, glands that secrete things. Your heart rate can go up, pupils can dilate, etc. Those are your visceral reflexes. And then the complexity. It can be very complex with multiple circuits, multiple synapses. You can have 2 to several hundred going to multiple synapses, or it can be really simple because one synapse is right back out again. And it can be processed at 2 different sites. That's what people have to understand. You don't have to go to the brain for a response to be voted on by your body. The spinal cord can vote on a response and determine the correct answer, especially if it's something very painful or very damaging in the body, where damage is going to occur if you take the time to go to the brain. Okay? So you can have a spinal reflex, which is processed in the spinal cord, or you can have a cerebral or cranial reflex. which is processed in the brain. Okay, these are examples of innate reflexes. Infant sucking, burping, shivering, gagging, goosebumps. Those are all genetic. Okay, they're all determined by your body when you're born. You can all do that. Acquired reflexes. You salivate, you smell food. We bring donuts into the office a lot. Okay? We just bought popcorn from the Boy Scouts, all boxes of it. Okay? You bring that in, and the smells are good. You start salivating. Okay? It's a learned response. You have to learn that smell means you want something to eat, and it's going to taste good. Jumping out of the way of a broken bottle. If you're walking down the street talking to your friend, look down the ground, and there's glass broken underneath your foot. Do you stop and think what to do? No. You swing your foot out of the way so you don't step on the broken glass. But that's got to be learned. You got to learn that broken glass is going to hurt you. That's not something innate, not something you're born with. Moving your foot to the brake pedal at a red light. Pavlov's dog, where you celebrate the sound of a bell when he was taught. Okay? Let me get through this and we'll call it a night. Classification of reflexes, like I said, monosynaptic and polysynaptic. Monosynaptic is one segment of the spinal cord. It goes, one synapse, goes right back out. Comes in the ventral, goes out the dorsal. Goes in the dorsal, comes out the ventral. Polysynaptic can be 1 to several hundred. Okay? Integrates motor output from several spinal segments. You have multiple synapses. Okay. Here's a circuit which is this is a monosynaptic. Here's your stimulation. Comes in, there's one synapse in the spinal column, and goes right back out the ventral root, and you get a response. And polysynaptic. Here's your sensory input. Goes into neuron, goes across here to an inner neuron, goes across here to another inner neuron, and triggers this neuron for a motor response. Okay? That's polysynaptic. Monosynaptic versus polysynaptic. One neuron versus two or more. Stress reflex. We'll talk about this. We got a lot to go still, right? I'm trying to think how much we got left of this chapter. But we'll stop right here after this slide.
There's after this, we're on slide 73, and there's a total of 78 slides.
Oh, okay. We'll go a little bit longer. We'll see what we go about. We'll go about 9:15. That's a good time. So the stretch reflex. Stretch reflex stimulates the muscle, activates the sensory neuron, information is processed in the spinal cord, motor is activated, and the muscle contracts. Now that sounds all fine and dandy. You ever lay in bed in the morning, you first wake up, you kind of stretch your arms, stretch your legs. What can usually happen? You can get a cramp really quick, right? You can get a charley horse. You start stretching your legs out early morning. That's a stretch reflex. The muscle's relaxed. You've been asleep. Your body says the muscle should be relaxed. You stretch it. That activates the muscle. The muscle goes, no, it doesn't want to. So it pulls back and contracts the stretching that you're doing. It's a stretch reflex. And that creates the charley horse. And you'll learn as you get older, you don't stretch real big when you get up in the mornings because it triggers a lot of charley horses and those hurt. Okay? So you stretch slowly. That's a stretch reflex. The muscle's being stretched and it says, no, it doesn't want to. It's in a relaxed state. And it contracts really hard. And that's when you get that cramp in that charley horse. That's a spinal reflex. That's a stretch reflex. Okay? So here's what a stretch reflex does. The muscle gets stretched as you wake up. It's activated. Okay? Goes to here and comes up. Is this a monosynaptic or a polysynaptic reflex?
Mono.
Mono. Perfect. There's one synapse right there. Okay. This is your reflex arc. This is the patella. The old hammer, you put the little hammer, the knee goes up. Okay. That's your reflex arc. It comes in, your input, your stimulus, comes in, spinal cord through the dorsal root, ventral root, contracts the muscle from the stimulus, and leg jerks up. That's your patellar reflex, which they check for. All right, let's put these in proper order. Grabbing a falling object from the table. Something falls to the table, you reach to grab it. You don't think about it, you just reach to grab it. What kind of reflex? Innate or acquired?
Nate.
Are you born with that? Acquired, right? You don't know. If it's falling off the table, will the baby grab it? No. They don't know what it's going to do. They don't know what's going to break, or they haven't learned that yet. You have to learn it's going to break, and you learn to grab it. I went too far. Okay, that's a knee. Okay, pupil shrink response to light.
Innate.
There you go. That's innate. That's automatic. Shine a light in the baby's eyes, they constrict. That's an innate reflex. Shivering.
Innate.
Innate.
Okay. Body shiver. Okay. Burping.
Innate.
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 Okay. My wife said that's acquired. She doesn't like me doing that. But that's an innate reflex. You know, he's blaming on that. Red light, foot to brake.
Acquired.
Acquired.
That's acquired. You got to learn what a red light is. Okay. Pavlov's dog.
Acquired.
Acquired.
Acquired. Okay. Infant sucking.
Innate.
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 Innate. Yeah, it's innate. They're born, they put it with the breast and they start sucking. Catching an object thrown at you.
Acquired.
That's
Acquired.
acquired. Okay? Throw an object at a kid, it's going to hit him in the head, right? You're not going to move. You haven't learned it's going to hit him yet. Pickup.
Innate.
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 Okay. Perfect. Gagging.
Innate.
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 Innate. Yep. Yawning.
Innate.
Innate.
Hey, young, get more oxygen. Goosebumps.
Innate.
Innate.
Innate. And salivating at the smell of food.
Acquired.
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 Fire. You got to learn what tastes good when you salivate.